school in Munster. She was a medical physicist at the University Hospital Munster, Germany, and also deputy head of the Physiotechnical Quality Control at the Reference Center for Mammography Munster. She has completed her Masters of Science in Medical Physics at the T.H. Mittelhessen University of Applied Sciences in Gießen, Germany, and Diploma in Medical Engineering at the University of Applied Sciences in Gießen. Her Bachelor of Science is a first-class honors in Biomedical Engineering at the University of Ulster in Jordanstown, Northern Ireland. She has completed her Bachelor of Engineering in Clinical Engineering at the University of Applied Sciences in Gießen. Also, she is a member of German Röntgen Society and Physics and Technology Task Group, APT. Madam, over to you.
Thank you much for your introduction. I'd also like to say hello to everyone, probably good evening to most of you. And today I would like to talk about dose matrix in diagnostic radiology and what you can do by simply looking at those data, how you can calibrate your data, how you can verify data, and how you can simply find errors or other problems simply by looking at those data. I'd like to begin with a short background about medical physics here in Germany. Medical physicists are well established in radiation therapy and nuclear medicine. They have been working there for many, many years, doing the quality assurance or doing the radiation therapy planning, but they are not very familiar in diagnostic radiology. That has changed when a new radiation protection law was introduced in 2018. And now medical physicists are required for all examinations with high exposure, which means in diagnostic radiology, mainly computed tomography and interventional radiology. So roughly in Germany, we have about 150 medical physicists working in the field of diagnostic radiology, which is not really high number. So what exactly is our purpose in diagnostic radiology? First of all, the most important one is that we are responsible for dosimetry. And then everything that has to do with the optimization process of radiation protection measures. That includes, of course, the quality control or quality assurance. That means that we are the ones carrying out constancy tests, or we're dealing with authorities when it comes to quality control. But we are also involved in the selection of new X-ray systems, of personal protective equipment, dosimeters, and everything like that. Also, of course, when new X-ray rooms are supposed to be planned, we are involved in the planning process. Then one important point is also that we are the ones responsible for the training of radiologists and radiographers and everyone else working in the radiology department, because they don't have the necessary physics background or the deep background as we have as physicists. And very important, we are responsible for the monitoring of patient exposure and comparing the exposure to diagnostic reference levels. And when we have those, we can consequently optimize the exposure. And that goes back to the responsibility for the dosimetry, which I mentioned earlier. I'm just going to put my pointer here to the laser pointer so I can show you something later on. So as was mentioned earlier, I work at the University Hospital in Frankfurt. Right now we have 5 CT scanners in the hospital, 11 interventional radiology suites for the different departments like radiology department, neuroradiology, cardiology. We have 23 mobile C-arm units, which are used in the operating theaters, 21 mobile and stationary X-ray units for just regular projection radiography, and then various others like specialized equipment for mammography, cone beam CT, and so on. So the key principles of radiology of radiological protection are probably known to everyone. The first one is the justification. So before you actually expose a patient to radiation, you have to be sure that this radiation exposure is doing more good than harm. That is something that usually the doctors are responsible for, that they decide that the radiation exposure is actually necessary, and the patient is benefiting more from the exposure than from the risk involved in the exposure. The second point is the optimization. That is the famous known ALARA principle. It means that the number of people exposed and the magnitude of the individual doses should be kept as low as reasonably achievable, meaning that you do not only have to apply to certain dose reference levels, but you have to try to be lower as those levels and optimize your system. And then the last one is the application of those limits. That means the total dose to everyone other than patients should not exceed appropriate limits. That means everyone working, for example, in a radiology department should not be exposed to high doses during the exposure, and you shouldn't exceed any limits. And as a medical physicist, we focus now on the optimization process. One way to achieve that is by using dose matrices. And well, what is a dose matrix? Generally, it's just an instrument for the visualization of dose distributions. And it's a wonderful tool to show dependencies. For example, the dose versus the age, or the dose of certain tissues, organs, the gender, for example, because we all know that, for example, the breast of a female patient is more radiosensitive than those of a male patient. We can also show radiological procedures or compare them. We can show doses from different vendors. If you have systems of different vendors, compare those. And there we can use dose matrices. There are different types you can use. The easiest type is probably a table, but more commonly used are different types of graphs, like 2-dimensional, 3-dimensional, just because it's a nicer way of visualization. Before we go into those different dose matrices and into the actual examples I have prepared for you, I'd like to repeat a few dose quantities. And the first one is the effective dose. It is a radiological protection quantity and an instrument that can be used for optimization and for comparing radiological techniques or protection procedures. So for example, if you want to compare the dose of a chest CT scan with the dose of a chest radiograph, you can use the effective dose because the dose values you get from your X-ray systems or from your CT scanners are different, but the effective dose makes it easy to compare. What's very important is that the effective dose was never meant for individual risk assessment. It's always important to stress that when it comes to everyone not with a physical background, like radiologists, radiographers, patients, they are usually not aware of this fact. And the effective dose cannot be measured directly, but instead it has to be calculated, usually from weighted organ doses, by taking the values you have from your system, your dose values, and apply conversion factors. Those are, of course, not very accurate. They're just a rough estimate, and they usually don't take into consideration that you have different types of patients. They usually have like one adult patient and not, for example, different genders or different age groups. That gets a bit more accurate when you use Monte Carlo simulations, but still there are some error margins we are dealing with. So take the effective dose as something that is a good rough estimation, but nothing more than that. If you want to calculate the effective dose in computed tomography, for example, you can start with a dose measurement in a phantom. You're aware that we have two different phantoms in computed tomography, a small one for the head and a bigger one for the body. The smaller one has a diameter of 160 millimeters and the bigger one of 320. And there you can do your dose measurements. And from those measurements, you can then calculate your CTDI wall. If you know the scanning lengths, you can then compute the dose length product and multiply it with certain conversion factors, and then you have your effective dose. The second dose quantity I'd like to point out is the peak skin dose, often abbreviated with PSD. And as the name already states, it is the highest dose to a single area of the skin, and it has the units of gray. It is quite an important dose quantity in interventional radiology, because there we deal with high doses, or sometimes we deal with high doses, and those doses sometimes even exceed the dose limits for deterministic effects, which means we might damage the skin of the patient. So the peak skin dose should be always kept in mind when we're doing interventional radiology. In theory, obviously, you could measure the peak skin dose by placing a range of dose meters on the patient before the examination, but that is usually not done. Most of the time, it is also calculated by using the values you get from your system, like the Kerma area product, KAP, or the dose area product, DAP, and again, multiplying it with conversion factors, or what is also quite often taken is the reference point air Kerma, which is a good estimation for the peak skin dose. Just a short revision on what is actually the reference point air Kerma, or where is the reference point. This is the definition according to the International Electronics Committee. There are also some other definitions, but this is the most commonly used one. You have your C-arm here, and in the middle between the source and your detector, you have your isocenter. And when you move from your isocenter 15 centimeters towards your source, then you find your interventional reference point. These 15 centimeters are not just chosen completely arbitrary, but they actually make sense when you look at this example here on the right side. If you have a standard patient, then you place the patient in the middle of the isocenter, and then your interventional reference points happen to be exactly on the skin, which means in that case, the interventional reference point, or the dose at the interventional reference points, equals to your peak skin dose. Of course, this is only for standard parameters, and if you have a standard patient, if you have other parameters, anything deviating from that, then the interventional reference point is not so accurate as the description for the peak skin dose. So for example, here on the left, if you put the table or the patient higher and move it closer to the detector and further away from your tube, which is actually supposed to be good because you're lowering the dose for your patient, then it means that the interventional reference point happens to be outside the body and not on the skin. So you're overestimating the dose in this case. On the other hand, if you, for example, have a bigger patient, then you have to put the table lower. It also happens if you are working with a small radiologists. They usually also have to put the table lower, moving it closer towards your tube. And that means that the interventional reference points happen to be inside the body. And in that case, you would underestimate the dose to your patient. But of course, it's still a good estimation. And as long as you keep those points in mind, you can use the interventional reference point as a good estimation for the peak skin dose. So here's an example of a dose matrix that the International Committee on Radiation Protection published in their publication 101. It is meant to show the collective dose to a whole population. It's also done by showing the different effective doses that people received. And you can see that they divided the collective doses in different types. For example, here you have the duration of the exposure. You have short-term exposure, medium-term exposure, and long-term exposure. Then you also define it on a geographical level, global exposure, and here the local exposure, and then also the different ranges of individual doses from high, medium to low. This is a very global way of dose matrix and something that is not really often done in diagnostic radiology. So I'm going to show you a different example. This is something you might often see, for example, when you want to look at the peak skin dose of a patient. Here you can see the peak skin dose or the different doses of the patient during an interventional procedure and how they are distributed over the patient. It is shown in a two-dimensional way. You can see here the cranial and the caudal direction, so from head to toe, and the angulation to the right and to the left. You can see here different doses. And here at this point, it is the highest doses that would be your peak skin dose. And it is also color coded, so you immediately know if it's exceeding any dose limits. You might also be familiar with an image like this. Some systems also display the peak skin dose on a phantom. They map those color code dose distributions on this phantom, so it is easier to see where the patient actually was exposed. And you can see also here, it's a perfectly square shape, that it was a radiological intervention to the head, and that here in the area, it was the highest dose, and you have the level red, which means the doses were pretty high. Now I'd like to go into some real examples, not all this theoretical stuff, but to show you how you can use your own dose data again to find errors in your systems and to optimize it. This is an example of our dose values for a trauma scan of the head at the CT. We do that quite frequently for patients who had accidents or who simply got into a fight. It is to check for fractures in the dental or facial maxillary area. And you have dose values for two different CTs, CT1 and CT2. The mean CTDI vol is displayed here, and the dose reference level here in Germany would be 8 milligray. And you can see that both our systems are well below those reference levels. So the first thing we can say is that we are good. We are below those levels. But of course, that's not enough. You can also see here that there's a huge difference between those two systems. Actually, it's a factor of 3, which is quite high. Part of it can obviously be attributed to the fact that our CT scanner 2 is a more modern scanner and has certain features to reduce radiation and to reduce dose, but not all of it. So when you see such a high difference, you should have a closer look at the protocols, and you can find out what was the reason here by simply looking at the dose report the CT scanner gives you. Here you have your CTDI vol in your dose report, and what you can see behind the actual dose value is the letter L, which stands for the large phantom, and the large phantom obviously is the body phantom. It is used here from the scanner to compute the CTDI vol or to calculate it, and we are actually doing a scan of the head and using the larger phantom or the body phantom here in this case would be completely wrong. And so the dose is underestimated or calculated too low just by the fact that the wrong phantom was used in this case. So you can simply correct it by using a conversion factor to get from your large phantom to your small phantom. And then instead of having a value of something like 2.6, you're now at 4.4, which is a bit higher, still below this value, but at least you have now the correct value. A different problem we had at our radiology department was with a scan of the neck, again, computed tomography. You can see here different dose values over a certain time period. The red line here indicates the dose reference level, which is 15 milligrays, or a CTDI of 15 milligrays for the neck. And the green dashed line here indicates the mean values for our neck scan. So generally we can say we are at roughly 2/3 of the dose reference level, so we're even better than before, I would say. But what you can also see up here, that there are some values really exceeding the dose reference level. For example, if you take the values here, those are more than 3 times above our mean and more than twice the dose reference level. So the big question is, where do those high values come from? And if you only have a few of those values, it makes it even more, or you're even wondering more where those levels come from. So you can also try to come up with some ideas. My first idea was maybe we're dealing with obese patients. Those patients obviously need more dose, but when we look here at the topogram, the overview scan of the patients, you can already see that this patient does not look very big. And if you have the exact body measurements, the patient was 180 centimeters with 79 kilograms, which is a body mass index of 24, which is still in the normal range for a European. So we can say that is nothing to do with obesity or with bigger patients. So you have to come up with a new idea. And you can see here that in this image, you can see that the patient has had some dental work done. And so your second idea could be maybe metal implants are responsible for the increase in dose. So what you can do now is to have a closer look at the dose distribution along this Z-axis or along the patient. And that's what you can see here. So if we look roughly here at this area, we can see maybe a few little ripples, but we cannot see anything that's really remotely explaining the high doses we had. No high increase here in this area, so we can say no, the metal implants are also not responsible for the high doses. But if you look closer at the dose distribution, then you notice this is not a normal dose distribution, because the correct dose modulation or the tube current modulation would be something like you have here on the left. In this area, you would have the shoulders of the patient, then here the actual neck, and here the head area. So something like this. And for the patients where the doses were so high, you have a modulation like this. So it's actually the other way around. In the shoulder area, you start with the lowest doses, and then it is increasing here when you come to the head. So you know something is wrong with your dose modulation simply by looking at those dose values. And of course, now you want to find out what actually caused this wrong modulation, and you can find the answer when you have a look at the DICOM header, and specifically at this DICOM tag here at the body part examined, because it says chest. And actually we were scanning a neck, so the chest requires a topogram or an overview image in the anterior posterior way. And since we were doing a neck scan, we had only a lateral topograph. So what does this actually mean? If we only have one topogram, so if we're only doing the neck scan and we only have this lateral topogram, then obviously the scanner is using that for the tube current modulation, or as the basis for the tube current modulation. But if we are not only doing a scan of the neck, but for example, a second scan in the same examination of the chest, then you have two topograms, one in the lateral view and one in the anterior posterior view. And the body part chest requires this anterior posterior topogram. So even if you're doing the neck scan, if you're doing all your planning on this topogram, then the CT scanner uses this topogram here for your tube current modulation. And you can obviously see that there's a huge problem because it ends here. And so the CT scanner doesn't know what to do when you're going up here for a scan of the neck. And so it is increasing the dose because it just doesn't know what to do. Just a short background on tube current modulation in computed tomography. The easiest way would be to use a constant tube current simply based on patient size. This would be something like this when you have a scan of the chest, the abdomen and pelvis area. So we are just using a constant tube current no matter where we are or in which slice we actually are. If we're having a bigger patient, we would simply increase the dose and use a line somewhere up here. If you have a smaller patient, you would decrease the dose and use a straight line down here. Obviously, this is not perfectly not perfect for complete scan of the body because the chest area with your lungs doesn't require as much dose as the rest of your body. So the tube current modulation is firstly done along the patient, so along with that axis. You start with a very high dose here in your shoulder areas, then it is going down. Here in your lungs, you don't need as much dose. And then depending on the size of the patient, it is increasing again. If you have a very big patient, then it would be somewhere up here. If it's a bit smaller one, then the dose isn't increased as much. Still, this isn't perfect for every patient because usually a patient isn't shaped as a perfect circle, but more like in elliptical shape. So the dose is also modulated along the X and Y axis. It means along during one rotation of the scanner. It means that usually in the lateral direction where the patient is bigger, it is increasing the dose. And then when you go in the anterior posterior or posterior anterior direction, it is decreasing the dose. And so it would look something like this. And the last type of tube current modulation would be an organ-based modulation. You cannot see this in this image here, but instead you have to look at this small graph. The dose is reduced in a certain or during a certain angulation of the tube to reduce the dose on very radiosensitive organs, for example, the breast or the islands of the patient, and to keep the image quality constant, the dose that was taken away from this part is then added to. So during a whole rotation of the scanner, you would have the same CT/I than you would have without the organ-based modulation. Different vendors use tube current modulation in a different way. You have here two patients with hip implants, and you can see here on the left side that the CT scanner recognizes that there is an object there that is absorbing a lot of dose. So it is increasing the dose to a very high level and then decreasing it again. On the other hand, here on the right-hand side, this scanner also recognizes that there are metal artifact implants, but it is not increasing the dose. Instead, it is using some metal artifact reduction so that it doesn't have to expose the patient to high dose values. Also, one point that you have to keep in mind for the tube current modulation is that you have to place your patient directly in the isocenter, like this one here. So if you take an anterior-posterior topogram image, then this would result in a patient size, according to this arrow here, if you are placing the patients too high, if you are putting the patient table too high, then the patient wouldn't be in the ISO center anymore, and that leads to a magnification then in the topogram image. That is the different arrow here, and you can already see that it's bigger now, and that means that the CT scanner thinks the patient is bigger, even though you are working with the same patient. I have two examples here. In this case, this patient was perfectly positioned in the ISO center and has roughly a diameter of 28 centimeters, which led to a dose of 4.3 milligray as the CTDI. Then that same patient had to be scanned again just a few days later, and you can see here that the patient was not perfectly placed in the ISO center. The table was a bit higher, so that led to a magnification of the patient. So in the image, it appears that the patient is roughly 31 centimeters wide, which means 3 centimeters more. And for the CT scanner, it is now a bigger patient, and that leads to a higher dose value of 6.2 milligrays. So you have 50% dose increase just because you're not properly positioning the patient, and just those 3 centimeters result in 50% more dose. So the tube current modulation is a very good tool to adjust the dose, but it also has some sources of error where you have to check regularly and perhaps train your radiographers if it's not working in a good fashion. So coming back to some examples, it's again a CT scan, this time of the chest. You can see here that the dose reference level is 10 milligrays, and you have values from 3 different CT scanners. And you can already see that the CT scanner 2 has the highest dose levels. And maybe if you remember from earlier, I said that our CT scanner 2 is the most modern scanner we have, then it's actually a huge question, where do those high dose values come from? If you compare it, for example, to scanner 3, there's a factor of about 2 between those scanners. And that's actually really, really strange if you consider that this is the most modern scanner. So we had a closer look into the different protocols we were using at those different CT scanners. And we found out that at the other scanners, we were using iterative reconstruction. I think you will hear more about it later on in this course. So I'm not going into the details of that. But iterative reconstruction leads to a better image quality, and because you have a better image quality, you can work with lower doses. And CT scanner 2 was not using iterative reconstruction, just the standard filtered back production. And because of that, we had to use higher doses. And when we adjusted that, we were able to reduce the dose also to a much lower level. So we ended up with half the dose that we had before. Moving away from all the computer tomography examples and into the interventional angiography, here in Germany, we have something called significant events. They were also introduced with the new radiation protection law in 2018. And those significant events are just all accidental and unintended exposures. And if they are very severe, we have to report it to authorities. And severe in this case means for diagnostic angiography, when the dose area product exceeds 20,000 micrograys times square meters, or in interventional radiography, when we have a dose area product of higher than 50,000. And in addition to that, when the patient also has a skin injury of grade 2 or higher, so not just little redness after the examination, but really severe injuries, then we have to report it to the authorities. So I'm going to show you some of our numbers from last year. So in 2020, we had more than 2,400 studies just for our general radiology department, so excluding neuroradiology or cardiology, just general radiology. Out of those 2,430 had values with a dose area product of 50,000 or more. So roughly 1% of all examinations have high dose levels. But from those 30, only one exceeded a peak skin dose of 5 gray. And maybe you remember that 5 gray is the value where those skin injuries of grade 2 or higher can actually occur. So if you're staying below the level of 5 gray, you cannot actually have those because there are deterministic effects. So only one patient out of those 2,400 might have a skin injury. Then we had 10 where we exceeded the value of 2 grays, where you can find maybe mild injuries like little redness of the skin, but no severe injuries. But out of those 30 interventions, just in addition to those 30 interventions, we also had 3 interventions where the dose level was below 50 micrograys times square meter. So actually below this reporting threshold, but we still had a peak skin dose of more than 2 gray. Altogether, we had no patient with skin injuries, which is obviously best way it could happen. But this whole process of looking at the doses or this dose level and then examining the patient is quite a lot of work. It means, because if we were actually sticking to what the law says, every time we have a patient that exceeds this value, so it would be those 30 patients, we would have to call the patient back and check if the patient has any severe injuries. That means a lot of work. It also means that we are troubling the patient, that the patient is worrying because we are telling the patient that he or she has received high dose levels. So this is not ideal. So instead, we are doing it a different way, and that is by using dose distributions here for the peak skin doses. Here can have 2 patients who have received roughly the same dose area product. On the left-hand side, you can see that the dose was distributed quite evenly on the same spot, and so it resulted in a peak skin dose of 2.7 grays. On the right-hand side, on the other hand, the dose was distributed more, so the radiologist angulated the system quite a lot, and so the dose was distributed more evenly across the skin of the patient, and so it resulted in a peak skin dose of only 1.1 gray. So even if you have the same dose area product, it doesn't mean automatically that you have the same peak skin dose. So there's a huge difference, more than twice on this side. And it means that not because you're exceeding the 50,000 microgray times square meters, which is the reporting level for us, that we're actually damaging the skin of the patient. So we only check for skin injuries and call a patient back when we can see here from those graphs that the peak skin dose is actually exceeding 2 gray. It is still not the limiting value for deterministic effects of grade 2 or higher, which is 5 gray, but we use that as a little bit of error margin. So if the calculation in this case is not absolutely correct, we can still find skin injuries if they happen just be above 2 gray. Then one examination that we do quite frequently is the transarterial chemoembolisation. Maybe you've heard of the TACE. It is an interventional procedure that is used to block the blood flow to tumor areas, quite often done of liver tumors. And you have here the different dose values over a certain time period of 2 of our systems. You can see that the dose reference level is up here at 23,000. And we have here the actual values much lower than that. There are a few values a bit higher, but in this case, it can really be attributed to these patients. But let's have a closer look at the values down there. And you can see that the values here from the system 1 have a mean value of roughly 1,500, while the system 2 only has 500. So there's a difference of factor of 3. And again, by looking at this graph, you can find out that you have to optimize the system here, Angio system 1, while this is much better. The problem in this case was that Angio system 1 is an older system, so we do not have really much we can optimize in this case. So the only thing we can do is to try to use this system more, the second one, because it can work with lower doses, especially when we are working on children or younger patients. Then it is better to use the system 2, which is working with lower doses. Then one example from our neuroradiology department for cerebral angiography, you can see here the dose levels of different radiologists. So the box plots indicate here the median values, and then the 25 and 75 percentile and the min and max values. And as you can probably see right away, the value here from the first examiner are the highest. So there you can say that this person either needs some more training or some more experience, but it could also be that it is a senior physician who is just doing the more complicated procedures. That would also be a reason for higher values. So let's have a closer look at that. And you can see, no, this one here is a younger radiologist with just a few years of experience, while the senior physicians down here have much lower values than this one. And you can see as well that here the boxes are much smaller. And that is also typical for senior physicians because they just so experienced that they usually end up at a certain dose values, while for younger, unexperienced fellows, the doses are just varying higher from procedure to procedure. Then the last topic I would like to cover is the just normal projection radiography. Start here with how you can see the doses from the images. You know that from just classical film radiography, you can see right away if this is your ideal image. If you have too much dose, then the image becomes too black. If you don't use enough dose, then it's still white. When you move to the digital world and use a digital detector, it is not that straightforward anymore. So again, you have here your ideal image. And if you're using not enough dose, then of course, at some point you have too much noise in your image and you will see that the image is not perfect and there's something wrong. But on the other hand here, it is much more difficult because you don't really see that you're using too much dose. And to overcome this problem, the different manufacturers introduced exposure indicators that are supposed to tell you if or what exactly, if you're using too much dose or if you're using right dose values. In the beginning, every manufacturer, every vendor had their own specific exposure indicators. You have some of the names here. Even the way they were calculated differed from vendor to vendor. Some had a linear approach to the dose. Sometimes the dose was more logarithmic way. So others had or made it so that way that if the exposure indicator increased, then the dose values also increased. For others, it was exactly the other way around. If you increased the doses, the exposure index became lower. So there was a really wide range of exposure indicators and of values that the radiographers had to keep in mind. And to overcome this problem, a standard exposure index was introduced, and not only the exposure index itself, but also a target value and a deviation index that shows you how much your actual exposure deviates from the target value. The good thing about this standard value is that this exposure index is proportional to dose. So you can simply divide it by 100, at least in calibration conditions. And then you have the dose that your detector receives. And your deviation index is computed in a way that it corresponds to steps on the density or MAS control on your system. So you can see here, ideally, your deviation index should be roughly around 0. If the value is higher than 0, then it's an overexposure. If it's below 0, it's an underexposure. So what can you now do with those exposure index values? And here we have an example of one of our mobile units that is used in the intensive care unit. It's a new system that we bought last year. So during the Corona pandemic, it was not possible for the specialist from our vendor to accompany the radiographers to the intensive care unit and to configure the system properly. So unfortunately, we had to work with standard parameters, and that resulted in an image like this. So maybe you can see that it's not ideal, that the image quality is not perfect. And you can see it also from the values here. The exposure index is way too low, or way below the target value, which is 200. And so the deviation index is well below 0. And that means that you actually have to do something and that you have to adjust the values. But as I already said earlier, you can see that the image quality is not perfect from the image. On the other hand, we have another example from a different system that you can see here. And you would say the image quality is not bad, but if you look again at your exposure index and the deviation index, you suddenly see that the deviation index is much higher than the 0 we should have. So this patient was overexposed. So because you cannot see it in this image, you should always look at the deviation index and see what you can do if it is necessary to adjust the parameters. And it's of course possible that those cases were just single incidents. So it's let's have a look at the different values here. And those are the values from those two systems. You can see here that is the new system. And you can see that the deviation index is always almost at a -4. And here on the other hand, the second system is always way below, above 0. So what you would do is adjust both systems, lower the dose on the first system, and increase the dose on the second system. And in the end, I'd like to show you another example, this time from our stationary equipment, again, chest radiographies. And you can see here that the dose area product or the dose reference level of 15 is here, and that our normal values are also below this value. So again, we are good in most of the cases, but you can see that in sometimes here, we are exceeding those values, and they're actually always going quite high. So we again had to find what is causing those high values. And you can see it when you have a look at when those images were acquired. And I'm trying to put here some boxes to make it even more obvious. All those values here are carried out on a radiography system that is dedicated for chest radiography during our normal operating hours. Then outside of those operating hours, when the night shift is working, when there's only 1 or 2 radiographers, not a bunch of them. We are just working with one equipment, so they're not working with this dedicated chest radiography system, but on a system where also, for example, hand radiographs of the spine are required. And every time this other system was used, the dose values increased. So we were able to find out that this other system had a technical error, and every time this system was using the high voltages that are necessary for chest radiographs, it has a technical problem, and so we had to get the tube replaced. And that is, again, something you can find out simply by looking at your dose values. You can find out technical errors, and that is amazing just by looking at dose values. So to sum up, a dose matrix is a powerful tool you can use to verify the output of your system. So you should not always trust your system or the values that your system gives you, but you can verify the output. You can find technical errors. You can compare different systems, different protocols, and then correspondingly optimize your system. And you can also find topics that need to be trained. If maybe 1 or 2 of your radiologists or your radiographers are not good as the others, or if there are certain procedures that need to be optimized, you can simply find out by looking at those dose values. And now I'd like to thank you for your attention, and I'm already curious what questions you might have.
Yeah, thank you very much, different Catherine. I hope you all enjoyed this amazing lecture. Let's move towards the questions. First question we have from Juan Mani. What is criteria to be diagnostic radiology and radiation oncology physicist in Germany?
Well, first we have to study physics or medical physics, and then after we graduate from university, we need to have 1 year on-hand training, and then sometimes take, depending on where you live in Germany, we have different authorities who deal differently, then take an examination before you can become an official medical physics expert.
Thank you. Second question we have from Duminda Sattarasinghe. How do calculate effective dose using ESD without Monte Carlo?
Usually by using conversion factors. That's the easiest way, because you can find different conversion factors in the literature and then just use those with the values you have from your system.
Okay, third question is from Muhammad Yasin. What are the conversion factors for different modalities where we can get these conversion factors?
You can, again, just what I said, you can find them in literature. There are different ones from different groups who have published those. So you would have to look up those values, whatever you need. There are different ones for different areas of the body, for different modalities. Yeah, you would actually really have to look them up, whatever you need for your special case.
Thank you. This question is a little long. Alex has given this question. Does the DAP and displayed air comma in an IR fluoroscopy equipment includes backscatter factor? Please suggest relevant documents or literature that gives conversion factors for converting DAP into effective dose in interventional radiology fluoroscopy equipments.
Yeah, it's again about the conversion factors. I think maybe I should look some up and provide them to you. I think it's easier it's easier for you than to look them up individually.
The next one is from Amir Ali. Are DAP meter readings reliable means of effective dose calculation for various X-ray performed procedures in general radiology?
you should always keep in mind that the DAP readings are obviously not perfectly accurate, but again, the effective dose is certainly not accurate at all. It should never be used for individual patients. It can only be used if you use it on a wide range of patients for optimization purposes or to compare it to other procedures. So for those cases, the DIP meter readings are obviously good enough, but always keep in mind you have huge error margins when you're dealing with effective dose calculations.
So that question comes along with another part. If so, then kindly recommend certain literature for the conversion factors used for X-rays.
Yeah, I think I'm going to provide some of those literatures, some certain publications, some papers where you can find those values.
Okay. Then Samiksha is asking, what is effective uniform dose? Is it applicable in diagnostic radiology?
To be honest, I have no idea what exactly was meant with this.
Okay, we'll move to next question. Would you please explain about effective methods to reduce dose in contrast enhanced multiphase CT?
That's quite specific. I think you have another lecture on CT, so maybe you should ask that question again after that lecture or later on in the group discussion if that question is not answered after the lecture. I don't like to answer a question that maybe you hear later on during this course.
Okay, next question is from Wilson. How conversion factors are calculated for different organs and also conversion factors for different organs in CBCT examination if available?
The conversion factors are usually calculated by Monte Carlo simulations. You find, for example, some from the big publications like the ICRP. But again, I can provide some if it's easier for you. You also have some for cone beam CT, but it's not as many as you can find for other procedures like CT or just general radiography.
Okay, next question is from Dominder. How organ-based modulation dose? Is it by shifting the KVP?
Usually it is done by reducing or increasing the milliamperes of your system and not the KVP.
Next question from Mohammed Yasin. In one weave AP or lateral topogram enough for CT patients? If not, what will be the effect on patient dose?
That always depends on your system and also on the part of the body you are examining. For some system, it's perfectly fine if you just have one topogram, and then it doesn't matter whether it's the AP or the lateral topogram. For some examination, especially if you're doing like the spine, then some CT scanners require both topograms or both directions.
The next question, how the significant event dose level is determined?
You're probably talking about those 20,000 or 50,000 microradian times square meter. The level or the dose levels where you have deterministic effects are 2 gray for lower or just for mild skin injuries, and then 5 gray for higher or more severe skin injuries. And if you take those 20,000 or 50,000 and use it on a system where you have a field of 10 centimeters times 10 centimeters, and you're irradiating the same area of the skin throughout the whole procedure, then you can divide that 20,000 and 50,000 by those numbers, and then you end up by 2 and 5 gray. And that's how the authorities in Germany chose those levels. Obviously, you're not using a 10 by 10 centimeter field for every procedure. You're angulating your system, so those significant dose levels are really a rough estimate for possible skin injuries and are not perfectly fine. And that's why we are not sticking exactly to those levels, but using the peak skin dose.
Can we find PSD from DAP readings?
No, usually not. Some systems give you the DAP readings, and in addition to that, the PSD. Some systems do not have a peak skin dose. So then you would have to calculate it, and again, by using conversion factors, yeah.
That question is continuing. Would you like to please share a reference level of your hospital or Germany for CT and IR?
Yes, I can do that later on. I mean, we have those reference levels for certain examinations for CT and IR here in Germany, and then for examinations where we don't have those reference levels, I introduced some that we use just at my hospital. But I can share that with you if you're interested.
Next question. In Germany, do we have the limited dose per year for each patient, or everything depends on medicine doctor instruction?
In Germany, we just have the dose reference levels. So it's just a reference that we should not exceed. But of course, if we have to exceed it, then it is necessary. So a patient does not have really limiting values, just reference values.
Okay. Next question. Is it possible that different PSD for same DAP? If so, what could be the reason behind it?
Yes, you can have different peak skin doses for the same DAP values. That's what I showed in this one slide. When you're angulating your system, if you're using bigger fields during the intervention, then you might have a bigger or a smaller PSD, even though the DAP is the same.
Okay. Next question. How often do you do the DRL audit at your department?
That depends on how good we were in the last audit. If we are really good, then it's 1 out of after 3 years. If we were not that good, then it might be 6 months.
Okay. Next question. Is it possible to derive dose reference levels for CT without measuring them on phantom, rather looking at CTDI value recorded on the system of patients already exposed under specific scan protocol?
Yes, of course, you can do that. You can have a look at what your mean or median values for certain examinations are. And then you can take those as your dose reference levels, or you can use, for example, the 25 or 75 percentiles as those reference levels at your own institution.
Okay, next question is there any difference between dose matrix and dose metrics?
Well, dose matrix with MATRIX, it's just this way of this instrument of presentation your dose level, and those metrics are just measurements.
Next question. Do you recommend SSDE as a DRL quantity?
The SSDE is not always displayed by all systems. It is for some older systems not there. So in that case, you cannot use this as a dose reference level. The CTDI is always there, so it's usually easier just to use that one.
Okay, those are the questions that we have for today. And thank you very much again, Madam, for answering those questions and for the great lecture. It was a pleasure to have you with us.
Yes.
I would like to, yes.
Yeah, thank you very much. I will just give small comments. This excellent lectures you have given, Catherine, and because you see here also, this is a challenging subject, radio diagnostic. You cannot do the radiotherapy physicist and just a small minutes come to the radio diagnostic department and do something. This is not given. So you must have a physicist in the radio diagnostic and dealing with the challenges. Sometimes I think in radio diagnostic you have more tough than radiotherapy, because here is optimization question is very, very strong, and you must understand everything in this machine. Maybe, for example, CT, how the machine is constructed, how you measure the doses, and how you examine the patient. Yeah, but in sometimes radiotherapy, you do not know anything. Maybe less knowledge in the LINAC, still you can do. So it is a challenging. So we are very happy that the laws now make obligatory that the medical physicists work in the diagnostic. Yeah, and she has shown us with many practical examples how we optimize the dose. This is actually the challenging, and it is not only that we should think that the reference dose level, but another things she has showed, it is ALARA principle. And this is actually the challenging. You should place the dose as low as we can do that. So thank you once again for the excellent talk. I hope you will stay with us and come again and again and give us lectures and your experience in the German hospital. And people in our regions are also trying to come in this subject of diagnostic. And I'm very happy that many participants, they shows their interest and ask questions these 3 days. And I hope they will stay with us and make this course very interesting also in the coming days. Thank you, Catherine. Alles Gute. Ja, und alles Gute und bleib gesund.
Thank you very much. And thanks again for your attention.
Thank you very much. Thank you, our chairman, SCMPCR, Professor Dr. Ghulam Abu Zakaria, and entire team of SCMPCR whose effort has made this session a success. Thank you all participants, and also Dr. Franco Milano also is here. So thank you so much for being here today. We appreciate your presence. Next lecture is on 11th Friday at the same time, same place. Topic is QC in mammography, CR, DR, and X-ray. Thank you, everyone.
Thank you, all the participants. I would like to
Bye bye, everybody.
that we will shift our platform in our
Thank you very much.
SMPCR website. From 11th June, I will send all of you the user ID, password, and how to join the instruction. Thank you.
Yes, please also upload the lectures, all the lectures, or any participant want to have this lecture, please send them.
We will provide the lectures, presentation, and recording to the participants for their future use and for the examination.
Any comments, Franco Milano, Professor Franco Milano?
No, I listen. I am. It's okay. Just one comment on one slide where there are uncertainty bar. Very important. Very important. But anyway, we will have occasion to this.
Thank you so much. I would like to request all the participants, if they are present.
Thank you. We can close now.
Yeah. Thank you.
And maybe the participant come very punctual at the point, so they miss the introduction sometimes. Most of the participants come 5 minutes or 10 minutes later. I think it is better come 5 minutes earlier than 5 minutes later, because the beginning, they give the actually the aim of this lecture. So it must understand so that you can follow it very well. Please come in punctual 5 minutes earlier than 5 minutes later. Thank you.
Thank you so much.
Thank you, the whole team, for